before we officially start, I want to introduce you to Dr. Cecilia Garrido. She is interviewing for a second time for a position in joint arthroplasty. She's also very experienced in hip arthroscopy and other factors, and she's had a very extensive track record. So please welcome her. She's going to spend the first hour here and then head off to an aggressive interview trail. It's the second time around, so we're excited to have her here. And obviously I'll know Maureen.
Thank you.
So good morning. Thank you for letting me interrupt.
You're most welcome. Well, Happy New Year from me too, to all of you. We're about to start a new year in Research Grand Rounds when we sort of reset the clock on some of the topics, particularly the building blocks, and I'll talk a little bit about that today. I want to start with a reminder. So if you go to the research schedule for residence page on the web, you'll notice that January is the time when I need the R2s to have crystallized what they're going to do for their research program. I know that I've met with many of you, and a lot of you have got several ideas. I don't think there's anybody with no ideas. And so I need to know this month what it is you think you're going to do. So please be thinking about putting, it's not a big deal, I just want a paragraph from you on paper so I've got something in the records so I can see what you're planning to do for at least the first research project that you're going to do as part of your resident research requirement. So the menu today is, I'm going to start as usual with a review of an article written by one of your attendings. This one will be an article in which Doug Smith was involved, an interesting article that appeared in the New England Journal. We'll get to that in a moment. I'm then briefly going to deal with the first building block that we do for sort of research competencies, research administration, and that's a quick look at where to look for external funding for residents. And finally, the main event today is Dr. Wagner is going to talk to us, and I gave him a tentative title of Physician Exposure to Radiation During Surgery, a Research Opportunity. This is obviously an issue of great personal concern to all of you, and one in which Dr. Wagner has got some very interesting data he's going to share with you that he's collected from his clinical colleagues. So let's take a brief run through this paper. It's a paper called Robotic Leg Control with EMG Decoding in an Amputee with Nerve Transfers. A very nerdy paper, a very interesting paper to me, and I'm sure to many of you. I want to spend a moment because we talked about H-index and impact factors at the last Research Grand Rounds, and I want to say this appeared not as a full article in the New England Journal, but as a brief case report. This is a format that's actually accessible to any of you, and as you go through your careers. And I wanted to first say, why would it make a good idea to do this, and what are they? Well, brief reports usually describe 1 to 3 patients or a single family, so that's not very onerous. It's not a randomized controlled study. It's not a 10-year study. They're usually 2,000 words, pretty short, maximum 3 tables and figures, total of up to 25 references, and they have a brief summary of 100 words. Now, why would you consider putting an article in the New England Journal? Well, the first thing is that the New England Journal's most recent impact factor was 53.3. Now, that is a stunning impact factor compared to most orthopedic journals. Most orthopedic journals are in the 4s and the 5s. And you know what impact factor means? It means that in 2 years following the publication of your article, an impact factor of 5 means on average 5 people are going to cite your article in their article. Now, that's a pretty disappointing number for your magnum opus that you spent 24 months putting together. Only 5 people are going to actually, it doesn't mean 5 people will read it, but only 5 people are actually going to refer to that article over the next 2 years. But if it's in the New England Journal, an average of 53 people are going to refer to that article in the next 2 years. So if you're looking to make a name for yourself in a research context, clearly it makes most sense to you to publish in a high impact journal, such as, obviously the New England Journal is something we can, most of us, only just aspire to, particularly in surgery, since it's the New England Journal of Medicine. But nevertheless, it's worth a shot, and you can see that one of your attendings does have an article in the New England Journal recently with this impact factor. Another issue is how many readers does the New England Journal have? Well, it has 200,000 paid subscribers, and they believe that it reaches up to 400,000 readers each week. So again, for you to get known and get your name known to the broadest audience, the higher impact factor, the better. So I think that at first your main concern is just to get published anywhere. And if it's in a journal that has an impact factor of 1.8, then so be it. And just be happy that you got it published and that 1.8 people are going to refer to that in the next 2 years. But as you progress, you must be thinking about going for the highest rated impact factor journal possible. So that's a little preamble to this article. So what's the article about? It's the clinical application of robotic technology in powered prosthetic knees and ankles, and they have been limited by the absence of a control strategy. So it's an easy problem to make a prosthesis that's got motors on that control stiffness and are able to do powered extension. But it's not an easy problem to control the motors. This is a very interesting technique called targeted muscle reinnervation, and it's been successfully used in the upper extremity. And I'm going to describe to you what TMR is. It's a duplicate there, let's see. Whoops, I've got a couple of duplicate slides in there. So this is a case report of a 31-year-old man who underwent a knee disarticulation amputation 36 hours after a motorcycle collision. During amputation, 2 nerve transfers were performed to prevent neuroma formation. The severed sciatic nerve was separated into the tibial and the common peroneal branches. The small nerve branches were sutured over muscle end plate zones in a manner that I will show you. I'll show you diagrammatically rather than speaking. So it was the right leg. Here's the amputated sciatic nerve, and here is the novel procedure. So the root of the common fibular nerve was transferred over the long head of biceps, and the tibial nerve was sutured over the semitendinosus. And you well know, I don't really need, there's a better view of it, look. You can see where the transfers were made. Now, of course, the tibial nerve branches, the sciatic nerve branches into the tibial and the common fibula, and the common fibula has 2 branches. Most notably, the deep fibular nerve gives the primary innervation to the dorsiflexus of the foot, and the tibial nerve gives the primary motor innervation to the plantar flexus of the ankle. So the strategy here was to provide a muscular contraction in an unusual muscle when the subject imagined doing actions at a joint that he no longer had. So when the subject would innervate the muscle that was over the semimembranosus, then they would actually be thinking about plantar flexing the ankle, and vice versa with dorsiflexion. So here's the functional results, that a discrete muscle contraction developed in these newly innervated muscle fibers after several months. When the patient attempted to dorsiflex his missing foot, a contraction could be seen and palpated over the distal semitendinosus. And when the patient attempted to plantar flex, a contraction could be seen, measured, and palpated over the biceps femoris. The first thing they did was they had a sort of a video game where the patient was asked to control a virtual limb moving on the screen. And so they had a pattern recognition system. The patient was seated. They had 10 bipolar EMG surface electrodes over these innervated muscles and over the residual muscles that were not re-innervated. And here's what you see the result. This is a surface map. You can think of it as a map of the heat of the measured surface electromyograms. And you can see that this posterior view, you can see that during imagined knee extension, you could pick up activity here. During imagined knee flexion, you could pick up activity here. And here are the reinnervated muscles. During imagined dorsiflexion, you could pick up EMG there, and imagined plantar flexion, you could pick it up there. So you notice that there's quite a lot of overlap here, that these two particularly could be confused. Now here's the prosthesis. It's a battery. It's got 2 motors to control the knee ankle. It has 13 mechanical sensors. The total mass about 5 kilograms, which is actually less than the mass of the shank and foot. And it has a supracondylar suspension. The controlled variable is the stiffness of this joint. How stiff is it when you push on it? That's the controlled variable by all these muscle signals. And the control system took both the EMG data from surface electrodes and the data from the mechanical sensors. And the patient ambulated under 2 conditions during that test. The first was where it used both EMG and mechanical sensors, and the second was where it used mechanical sensors alone. And what they found was that the EMG control reduced error in the task performance on that sort of video game task by about 40%. So when you add EMG, instead of just sensors that know where the limb is, you get much more accuracy. There are some videos on the site, and I'll leave those for you to take a look at once this PowerPoint is presented. Now, as far as the results in gait were concerned, they found error rates in things like stair climbing, ramp walking, normal walking of about 13% with the mechanical sensors only. It was only 2.2% with mechanical sensors and residual EMG, and 1.8% with sensors, residual EMG, and reinnervated EMG. So this is not an overwhelming addition as far as the error rates, but what was notable was that critical errors, that is, errors where what the limb did could cause the patient to fall, they were totally eliminated with the enhanced control system. So a very unique control system. The patient could do many things with the enhanced control system. This was really a feasibility study that shows this is possible to do, and the future work really revolves around making it a clinically viable system. For example, EMG signals are necessary all the time for this to operate. So the patient has to wear this matrix of surface EMG signals all day long. These could be uncomfortable in the socket, they could cause pressure, sores, and also if there's movement artifact, then the control algorithm doesn't work. They need to improve the pattern recognition and the classification system, and finally they need to make the leg quieter. One can only imagine, probably was making a lot of noise. You know, it's like a squeaky hip. People are going to notice you, and they want to make it lighter and smaller. So a very interesting paper. It's really at the forefront of the field in lower extremity amputation technology. I think the neat aspect of this is this reinnovation to existing muscles that control imagined movements. Any questions about that? Any comments? Okay, so when you see Dr. Smith, just congratulate him on his article. So I mentioned at the beginning of the year, we have 12 building blocks that we're going to give you every month. Many of you have seen these already. Here they are. They're things that we believe that are basic skills for you in your growth as researchers. And the one I want to talk about today is the essential one, that you've got to have money before you can do research, unfortunately. So let's first talk about internal sources of money. You're all familiar with this, I think, our resident research grant. When the Blossom comes to the campus, it's time for you to submit a resident research grant. We provide money for you to do your research and to help you seek external funds. We'll give up to 6 grants on April the 30th. Applications are due on the 1st. We'll give 6 grants of up to $3,000. And you will remember that by applying for these, you are making an implicit commitment that you will apply for external funds within 12 months. And many of you have done this and done this successfully. These are on the website. These are the sections that we want you to address in the application. And this is the way we will score it. And not unexpectedly, that format is patterned after the kind of grants that we would like you to apply for. Many organizations, such as OREF, OTA, AOSSM, have resident grants. This one is particularly remunerative. Residents can apply for up to $30,000 in this one from AOSSCM. We have a page on the resident research website that Teresa Bergholz caretakes, and let's see if we can bring it up here. We may not be able to. There we go. It's behind the password, so it may be that, let's see if I can reduce the size of that and get it over a little bit. I think I may not be able to get it all on, but it's there for the looking. And as I say, what Teresa does with this is that she lists all of the societies to which you might be interested in applying. Here's AONA for trauma. Here's the Society of the Hand. Here's the OREF, another OTA. And she lists the deadlines and the amounts. And you should go there and take a look at who might fund a grant in your area of interest. Your colleagues in the past, as residents, have been awarded grants from all these institutions. Most notably, Dane and Kenny were successful with that group. I want to stress that you should involve Teresa as soon as possible. She is a great resource. She's there to help you. It's part of her job to help you get funds for your research. It's important that you define the barrier in your field, or the lack in present literature that you're going to fill, what's going to be the context for your hypothesis, and your aim should also address that you have mentorship from an attending with an interest in this area. It seems silly to say, but I do want to just emphasize that you have to be careful and precise in these things. You have to pay attention to organization, formatting, grammar, spelling. Have a colleague proofread your grant application. You know, there's no chance to get a grant if it's not well written. It shouldn't be, perhaps, but that's the way it is. It's the idea as well as the way it's presented. Ken, did you have something to add?
I just heard something very interesting from one of the people in charge of the OREF grants, is that they consider those grants a investment in a person as much as the project. And they are concerned that people don't submit for them because they think their project isn't novel enough. And for theirs at least, they don't care so much about that. They're interested both in the project and in the person who's submitted. They want orthopedics residents to do research. So you don't have to worry that your project's not novel enough for OREF. A lot of residency programs have every single person submit one in one of their junior years there, and those are the programs that are very successful in getting them.
Yeah.
So I think
they do that at special surgery, for example.
Hesitation to apply for that, even if you're like a 4 or even if you're a 5. I asked them specifically, so I know I'm going to apply next year as a 5, just because it seems like they have money they want to give away, and that there's no reason not to put your hat in the ring.
Yeah, I think that's exactly right. If you have both, so much the better. If you have a great personal application and a wonderful project. But I would also want to encourage more OREF submissions. Teresa's there to help you. Please use her. You need to notify us as soon as you think you're going to submit. On the research website, there's a button that says planning to submit. That brings us into the loop and helps you meet the deadlines that have to be met, because you do have to go through the research office and you can't do it the day before. It has to be they want 2 calendar weeks to have corrections after the initial submission. So you've got to be ahead of the game to get this in. So any questions about the whole issue of finding funding for your research? Those of you perhaps who, yes, please. You definitely can submit multiple. You can send the same proposal to multiple places. Unfortunately, you can't accept them both if you're successful, but you can and should to maximize the potential leverage of your effort. You should send to as many places as you can. Fortunate if you were in the situation to turn one down and choose the one that has the most funds. Okay. So, I now would like to go on to the third part of today's presentation. Dr. Wagner is going to talk to us about a particularly interesting study that came to him through some personal interactions with his colleagues and became much more. So I don't think we need more introduction, but Dr. Ted Wagner.
So I started, when I was a resident here, I had, they used to have a spinal cord injury service on rehab. And I joined and I came in as a rehab resident first year, and I spent 6 months with them. So I only tell you the story because what happened was that I looked up the cost of a decubiti and the care, and it was around $235,000 for 5 admissions for 6 weeks each for decubiti for a spinal cord injured patient. So that gave me a number that I could use for this sort of paper. So I decided that in Japan they were elevating trains by levitating them, by using super magnetic fields and then polarizing it so they could elevate the train. So I thought, well, maybe I could stick something into someone and levitate them. So I went down to Boeing and worked every night during a 6-month research time. And we developed a super magnetic field that would have a ring. And that ring was a piece of metal that we could put in and thread through the pelvis all the way around. And then this magnet, they could be elevated in a chair, so you could take about 70 pounds off of their sitting weight and do that. So when I left the residency, they referred to me as Crazy Wagner for a lot of good reasons, but that was one of the reasons. And so. And it turns around that maybe that's the way we should put prosthesis on. If you could put a piece of metal in a bone, develop a magnetic field, then you could have a prosthesis that was magnetically related, and you don't have to depend on skin pressure. So that was my thing. Anyway, it has nothing to do with the talk today, but I thought it was funny that I should walk into a study on prosthesis and presented by Peter. So today I want to give a talk, and it's really about a paper that started in 2005. And the reasons for the study were that in 2004, Ed Dawson was the president of the SRS, and I sat with him in the back of the room at the meeting in Quebec, and he was hoarse, and he said, you know, I just came back from Europe and I got this laryngitis, and he was dead at Christmas, and he died of thyroid cancer. The following year, Mark Asher, the president before him, was on an airplane and felt his neck and thought he felt a lump. And when he got operated on, he had follicular cancer of the thyroid. He's been operated on twice. He's lost his superior laryngeal nerve, and he still has disease. And then I made a short presentation to the Scoliosis Research Society, and a third surgeon came up and said that he had cancer in his family, so he got an ultrasound, and it turned out that he had thyroid cancer. So we had three cases that I became aware of, all within shortly, around about a year's time. So this led to an effort to survey the entire group. Now, some of these organizations have had a long history. In 1963, the Scoliosis Research Society was formed. And at the time that I'm here, we had about 700 members. And so I'm looking at a group of 700 members, but remember that about 40 of them had died or we were unable to get information. So we don't have 100%. But we were able to do some hard work. At that time, I actually hard copy mailed a request for the survey, and then we had 2 subsequent email requests. We had about 3,000 hits of different types out there on to get this information. And we were looking at the demographics, the duration, the shield time, personal cancer, and we're working with an hypothesis that this is all from radiation and radiation exposure. So of the 620 active members, we decided that we got a response from 553 males, and we decided not to include the female group because it was the information we got back was one factor, and 2, we just made it a pure study because the Scoliosis Research Society had been all male. And so almost all the females had been very recent members. So they didn't have a longitudinal study for them. Well, this is what you get. Now, this is an interesting thing because we had 63 members with cancer. And is this just the normal, or is this abnormal? And what we had was we had 3 cases of the thyroid cancer, and they happened to all have occurred in that somewhere around 2004, 2005. And then we had a reasonably high rate of skin cancers of one type or another. Colon cancer, we were a little surprised by, and we know that there were 2 other cases that we didn't get in the survey, but we knew from the history from the family that there may be 2 more brain cancers that were in that study. So again, not perfect because we don't have everybody, but we had an interesting deal. So what happened is that they have these SEER registrations for cancer. And so we had 3 in a population of 553. And this represented, by the statisticians, an 18-fold increase in the incidence of thyroid cancer in this single group. And that was presented to the Scoliosis Research Society. But there's some other shifting numbers that you have to know here. And so I'm presenting all of this because I really hope to get some comments and some direction to what I should really do with all this information. But in this study, you can see that the peak incidence of the thyroid cancer was out here in the 70s, and now by this last study, which was up 2001, the peak incidence of thyroid cancer is changing. Now, is that because there's better diagnostics? Is it because there's more awareness in certain areas for this? This is not a brand new concept that the thyroid gland is sensitive to radiation. That has been published, and it's published in the Chinese literature and a lot of other places. So I think it's probably more of an awareness and what's moving. But if you're going to compare your group to this, it turns out we're very close. Between 45 and 65 looks like the incidence. So it's not something that affected necessarily in the form of thyroid cancer the younger surgeons. But the younger surgeons need to look at this graph because this is out there and you need to know it, and it can be a horrible disease. Then the other way of looking at this is if you look at it and stratify it, the 30s had, by the expected thyroid cancer, 0 between 30 and 34. And you can see that you're pretty safe until you get to be about 50. And then this was the incidence for us. We had 2 at 55 to 59, and we had 2 at the 65 to 69-year-old, and for those total of 3. So again, it's not the peak incidence looks like it's forming at the after probably 3 decades of practice. So that's where you have to really step up and start thinking about the cumulative effect of this. And so we're going to look at it as a study again. You guys are all here at 35, at 25 to 35, and you're pretty safe. If you get up higher, you're up in the increased part. So when we divide it out and put it in a pie shape, it turns out that we've really developed more data than we expected to have. We started out as a thyroid study. Now we're looking at a total medical survey of a group of surgeons. You know, almost all surveys have been done on patients. There aren't any really surveys done on the doctors. There is a medical survey out of Boston that has collected a big bunch of data on doctors. You have to pay a lot of money to go in and work on that data. And they wanted almost $50,000 for me to go in and try to get a comparison view of people who didn't use radiation at all. So if you could get an internist who never was around radiation, we really, to do this study completely, we really need that other cohort. And I don't have that. And but it's very expensive to get it, and yet I think it should be shared. But that's the problem I had when I tried to get that. So now I've got 20% of us going to get prostate cancer, and 3% thyroid, 6% colon, and 50% are going to get skin problems. So this is the 2005 study. What was wrong with this study in 2005 was that, so this is a conclusion, I'll give that first, that it suggested the risk of thyroid cancer in the 5th and 6th decade of life or the 3rd and 4th decade of exposure. Likely the result of a cumulative exposure, and the hypothesis still needed to get an inclusion of a control group, which I didn't have. The other problem with this study was that we didn't know about the incidence of cataracts and other things that we thought should be part of the study. And so this was a direct criticism of the initial survey. But anyway, this is when we were in 2005, when I was starting to push hard to have everybody use the thyroid shields. And it's an interesting fact that only 40% of 1.5 centimeter lesions can be palpated. So palpation is not an early pickup for this. Question of ultrasound is, ultrasound gives you a lot of false positives when you start to do it. And so the thyroid scanning is going to cause a lot of concern and rundowns for people who don't have real disease, because there's a lot of cystic changes in your thyroid. They come out looking like different masses of different sizes. But at least a serial one at the time of high risk, which is in your 3rd decade of practice, may be the thing to do. And so we this was a picture taken in 2005. Jens wasn't wearing one, but then he got one. So this is about the time when it really started to change a great deal around the country. So radiation's been around since 1890. It's 120 years old, and it's causing a lot of problems. And I want you guys to become more and more and more aware of the radiation. And I think that the residents have to teach the faculty, and they have to start really thinking about our exposures. I am presently looking at a study to use ultrasound to replace X-rays for forearm fractures of kids, because I think we can very easily bring down the number by at least 25%. I went back and looked at an X-ray at children's for a forearm fracture is a minimum of about 7 or 8 X-rays, and they just aren't necessary. And I think when you look at that X-ray, that's very close to the breast and the ovary and the thyroid in every case. So we should be really changing that. The C-arm, understanding how the C-arm works is pretty important for the residents. So there's an emitting end to this, and you need to, they always ask you in those OIDI exams a little bit how the geometry works around it. And it's really the inverse square law, you know. So I want you to be well aware of how that all works. And the patient, if you move the patient's closer to the X-ray tube, the exposure rate quadruples when the patient is to the focal distance is halved. Okay, so you just need to know that as a little formula and check the right answer. And but it has to do with knowing when that machine's rolled in, you guys should know where you are and where it's standing and where the patient is, and think about it all the time. And spine abuses it terribly. So really be aware of it there. So this again was the 2002 image. And my comments about it was that we need to have now the SEER numbers for all the non-thyroid cancers, because we don't know that those other cancers might relate to the radiation, but we need to really know the background that we're looking here. So I haven't done the numbers on the thing, but I really present it as a great research way of looking at this in the future. The other I want you to be aware of, there are 4 thyroid cell types, and maybe all of thyroid cells are not affected by in the same way by radiation. The anaplastic one is the one that kills you within 3 months. Doesn't matter what you have, no matter what you do or what operation you have, and that's what Hank Dawson had. And the follicular ones and the others are much different presentation and treatment. Maybe we're developing actually a health status data survey of some sort for physicians, and that's a potential research project, I think, in itself, because if you could have one that worked, you could send this out to cardiology and radiology and neurosurgery and all those. We might learn a lot about our health groups. I'm suggesting ultrasound is a possibility for surgeons at risk for diagnosis. So the new survey, when we just got back last week, so I don't have the data. It's not been really put together, but I have Christy Benovich, my assistant, and she is in one day, one afternoon, tried to crunch all these kind of numbers, and it's not really fair to do that. But I can tell you a couple things, and that is that the new survey, which was done in conjunction with a guy from New York who's on the SRS board, and they're looking at it as a safety article, you know, information for their own surgeons. So together we added 8 new columns or questions. We had a combined response now from the 2 surveys of 936. In 2005 we had 509, and in 2013 we've got 427. So we now are 747 responses out of 1,100 members. Now there's some shifting data here a little bit, because we've come to almost double the membership of the Scoliosis Research Society. And that has a mixed group, because this is a very international society. And so some of these are senior surgeons who've joined. but many are young. So there's a very high young proportion in here. But if you really had a mean average of the age, I'm not sure that it's shifted as much as we think. But we need to know that information, and I don't have that. And then cataracts was a question we asked. But one of the most interesting parts of this is we added surgeons' comments about risk. And I'm going to show you an example of why that was pretty important. But these are the kind of questions that came out. And so we really wanted to know, did they use X-ray in the OR? What year did they start using, go from plain films? When did they start using the C-arm? When did they start using the shields? When did all this done? What is your routine? How many X-rays you take? So you learn a lot about different people's practices. And then, of course, we had all the dynamic questions about who they were and where they were. Where you practice has a little bit to do with it. The higher the altitude, the more radiation you get. If you go in a space shuttle, you're really in trouble because you can't protect yourself from the radiation. The reason that we can't go to the planets now outside with 3 and 4 generations is that we can't survive because of the radiation. We have no way to protect ourselves. So altitude is really a problem. And so we thought maybe in Denver and other places that there might be a higher rate of the cancer. So I won't go on too much more about this, but this is sort of where we are now with the 2013 cancer statistics. So we have thyroid. Thyroid was interesting because on the comment, one person wrote and said, I've had a cyst on my thyroid. It's been diagnosed with ultrasound. And a needle biopsy was negative. But when I called him this weekend, he's actually having his thyroid taken out this week. And so I think we can add him as another person in that group. There were many comments about surgeons who had had radiation done to themselves early in their life for acne, and which the thymus, of course, is radiated and maybe play a whole part in this thing. So you have to go back really and ask the question of whether reckless radiation was given to your parents' age and then even to yourselves. So we have about 4 other thyroids, I would say, that are at risk if you read all the comments. And I think the diagnosis hadn't been exactly secured. But the comments turned out to be a very important part of a survey, which I would not have thought about originally. And most people felt very strongly that radiation was the cause of the thyroid problems. There's a few reckless people who out there are cowboys who don't believe anything associates, and I'm sure they vote in a funny way nationally too. But anyway, they're out there. And then finally, so this is where we are at this time. It's interesting that the skin, that the melanoma is getting to be higher and higher. Now, whether melanoma has to do with people that have enough money to get out in the sun, or whether it's people who get a lot of radiation, or what the answer to that is, I don't know. But this is melanoma to head and neck, so it's pretty important. So I just acknowledge, and Dr. Lay is in Kansas City and is an epidemiologist who helped me with that first study and is willing to help on the next. And Dr. Asher, who has the thyroid cancer, is one who really encouraged the study. So with that, I would just like to open up a time for questions and maybe some comments as to how I should use this data or what we should do with it. Because this is not something that I trained to do. I trained to be an orthopedic surgeon, and now I'm in the thyroid cancer field, and so I'm interested. Any comments? Yes?
Are any other societies looking at this? I know the Scoliosis Research Society, but trauma or anything like that you've heard of?
Well, we haven't sent it out or suggested it to other groups, but the I am nailing people had a huge dose of radiation. remember, those people put their foot on the pedal and didn't take it off while they were reducing the femurs, and so I was part of that generation. But anyway, so I think the trauma people would probably be the next big group. Pediatrics is a great concern, though, because there you have the patient at risk, and a lot of the work that was done holding the fractures and then bringing in radiation, and so those two groups seem to have a high incidence. I don't know whether this is the perfect questions that we should be asking. And I think that if there were residents who felt that they could develop a health survey that would be of value for our own profession, I think it'd be great. And so yeah, I'm interested in the other groups. Yeah.
Dr. Hanley may be referring to the same people that you are, but actually, when I was on his service, he had referenced some colleagues that he knew that had thyroid cancer issues, and he actually switched to a larger thyroid shield. So I know he's thought about this as well, or maybe knows some other folks who are using all those.
Be happy to do that. Your lead shielding comes in all different thicknesses, and so you can get into the physics of that, and it's important. And the other is that the lead shielding should probably be all custom so that it fits you right, because it's pretty hard to stand for 4 or 5 hours for something that doesn't fit. And I know that the smaller, and some of those were women who had them, really appreciate having that. And things. I think maybe the residency should pay for that.
That's what I just said.
And
I like that, Dr. Wagner.
I provided all of the thyroid shields that came out about soon after this time, in 2007. I had your name on them all. But I did that a little bit through companies, and that's sort of illegal at the moment. So I can't do it that way. But I think that it would be a great thing, and it would probably something we should just fund right from the beginning. And seems as important as the iPad to me. But we'll see where we go with. Good comment, though.
Are you going to resend out the survey to try to get the rest of those 500 members? Or have you guys done sending them out?
Yeah, I've sort of worn out the society because I sent this thing 3 times. What you have to do, I learned something about surveys. People can't remember. You get so many surveys, you can't remember which ones you answered. So there is a certain, listen, I'm conscientious, but I can't remember whether I sent this one in or not. So subsequent surveys, you have to say, these are the people we haven't heard from. If your name's on this, would you please answer the survey? But you don't get everybody to come. It's disappointing that you think that the interest would be really high. I guess if you wanted to take it one step further, you could call every one of them, and that would be a massive thing. But it may be important enough to do. So, have any of you sent out surveys? Have anybody worked on a survey deal? Have you done it?
Yeah.
What was your response?
I think it was like 30%.
30%. So we are certainly at the group that's at risk for thyroid cancer. We've got a high percentage of those because of that 1,100, a lot of those are new members and are coming in and are younger into that thing. But it's nice because it's international. It's really truly international. Some of the international people are very, very conscientious. Some of them never heard of a survey, and they're not apt to do that kind of thing. So Peter, do you have any comment about the survey type of work and research?
Well, I think involving an epidemiological professional is really important. My experience has always been that if you're putting a toe in the water into something that's not your primary training, then getting a collaborator who has that primary training is like super important, and you're doing that. So I think that epidemiological professionals can provide important perspective and methodology that we perhaps wouldn't think of. I think that's the single most important thing that you're doing here.
Can you see can you see that the development of a universal survey for healthcare in surgeons might be of interest?
Well, I would think it would pay to look at some of the extensive surveys, such as the Nurses' Health Survey that are out there. They've been very successful Nurses' Health Survey, which have changed clinical practice over the years, been going for about 20 years. And I would be surprised if there aren't some physician surveys in certain specialties or subspecialties. And so I think looking at the waterfront is a very good thing to do. Is anybody familiar with physician health surveys in other contexts? Yeah,
I
you'll
think
probably
that there
also
may
be,
be, I think that radiology may have
you would think
something,
they
and I
would
need
be
to work in that area. The people who, the IR people are just, have been terribly exposed. But the question of going to lead glasses, I've never done that. And I don't know, how many residents here have lead glasses? Anybody?
More than once, and they almost made my nose fall.
But I think in a non-research context, the points you raised today are important for everybody in the room here from a personal point of view. You know, you're still not too far from that age where you feel indestructible, but you see that the results from older colleagues there, this is really, really important for your own personal health and something that you should really consider. Do we not provide thyroid shields to the moment?
No, they're the,
That really needs to change. That really needs to change.
and they are very, if they're very stiff, they're quite uncomfortable. And so again, the comfort for wearing the different shields, and another reason for having them customized.
So you don't wear them as a group in general, is that right? Who has purchased their own? Okay, about probably a third.
There are some available in the ORs, they're difficult to find, and they're often very tiny. So, yes, they're really aware. Right.
Yes?
I guess in the last 2 years, I remember one paper that showed actually the effectiveness of leaded glasses using like phantoms in the OR for pelvic cases, and I remember a similar paper showing the effectiveness of wearing like simple glasses to prevent splatter and kind of mucus contact with the eyes. But I think some of the reason why some people don't wear thyroid shields is that there's a perception that they don't cover the thyroid. The way that people wear them, that unless you wear them like a choker collar, they don't actually cover the thyroid. And I wonder if there are any studies out there that actually show that wearing a thyroid shield is actually effective at affecting this outcome, either in theory or how they're actually used. Because the way I see most people wear thyroid shields, it's not anywhere close to the thyroid.
You get trained in this, Kenny. Does anybody at any stage in your training come from radiological safety and talk to you about radiological safety?
Yes.
We had one discussion when we asked to look at the body.
But there's nobody actually as part of a boot camp, for example. I don't think we have it, right?
There's an online module.
An online module, okay.
Just like all the rest of them.
Would you want such a session? Is it valuable, or do you think you pick it up in other ways?
I think it'd be valuable if we can get them paid for.
Yeah.
And that may be one of the things we need to go to get there. And so that's right. As far as answering your question, you can cover your thyroid with the shield. If you wear them recklessly loose, you really just develop a pouch in the front that's open, and you get the radiation. So, but again, it depends where your radiation's being emitted. If the tube's upside down, then it's up high. If it's down below, then you can probably block it. So it has a lot to do with where you stand relative to it. You got to begin to think about that. Don't think of the C-arm as having two equal ends. They're not equal. Yes?
One thing that I work constantly with irradiation because I do hip arthroscopy, and one thing that it would be very helpful is to have a good communication between the radiologist and the orthopedic surgeon. I think there's not a common language, so whenever a new radiologist come in, you know that you will get more radiation. So I think we have
You're
to
absolutely
develop.
right. So you're talking about the tech who
Yes.
comes. No question. A tech to do a pedicle screw, somebody who understands the anatomy and has does it day in, day out. He takes one picture and makes a complete adjustment. Otherwise, you're talking about multiple shots, and people are very generous with that button. and they just will push it, and you're absolutely right. I don't think the surgeon should be given a disinterested tech, because that's really a big problem. I'm sure it's true for the pelvis too, and things that, actually, this surgeon who died was one of the guys who aimed his C-arm. He was known to have always grabbed the C-arm and turn it. And so he was that close to it and would hold it there while he pushed the button. And so he took a lot of radiation from it. No, it's a very interesting question.
Dr. Wagner, thanks very much indeed for a stimulating presentation.
Oh, yes. Questions?